Rahul. Rahul.
5, 4.
Okay. You can start now. Giving me
No
countdown.
problem, ma'am. Please intimate me when you want to start. No problem.
Yeah. Please. You can give me countdown now.
Sure.
Okay. Yeah.
5, 4, 3, 2, 1. We all are live now. We can start.
Good evening, everyone. I am Dr. Vaishali Gupte, Director Medical at Cipla, and it gives me great pleasure to welcome you to this webcast titled Stewardship in COVID-19 Therapeutics, Pandemic to Endemic. As you are aware, it has been a while since when India witnessed the third wave of COVID-19, and presently also there is surge in COVID-19 cases again. Objective of today's webcast is to understand from the experts in the field about the currently prevalent COVID-19 variants in India, clinical presentation of the COVID-19, whether it's different from the previous waves, and any updates pertaining to management protocols and role of newly introduced drugs in the management of COVID-19. We are extremely honored to have eminent faculty members for this discussion today. Our esteemed moderator is Dr. Shashank Joshi, sir. Dr. Shashank Joshi, sir, is endocrinologist at Lilavati Hospital and Joshi Clinic, Mumbai. He is the chair of International Diabetes Federation, Southeast Asia, and is a member of COVID-19 Maharashtra State Task Force. I really thank him for accepting our invitation. Our esteemed speakers and panel members are Dr. Subramaniam Swaminathan, sir. He is a Director, Infectious Diseases and Infection Control at Cliniclex Global Hospital, Chennai, and he Chair Infection Control Advisory Board Group at Cliniclex Global Hospitals Group. Dr. Jayanti Shastri, ma'am, she is a professor and head Department of Microbiology at TN Medical College and BYL Nair Hospital, Mumbai. She is in charge of Molecular Diagnostic Reference Lab at Kasturba Hospital and Infectious Diseases, Mumbai. Dr. Prashant Chhajar, sir, he is a Director, Lung Care and Sleep Center at Institute of Pulmonology, Medical Research and Development, Mumbai. I thank all of them for accepting our invitation. And with this brief introduction, I hand over session to Dr. Shashank Joshi, sir, to take it ahead. Thank you so much, sir. Thank you so much, everyone.
Thank you, Vaishali, for having this topic. We are very much in a silent cluster outbreaks of COVID Omicron variants. Our current aim after the first wave, second wave, and third wave clearly is now to save every life and ensure that there is least severe disease. That's really the aim of really the COVID pandemic, as we call it today. Now, WHO has still not declared the end of pandemic because worldwide numbers are very high. And the predominant variant in circulation still happens to be Omicron or its variants. And across different geographies from BA1 to BA5, we have something or the other in circulation. So I think the key in current COVID evolutionary biology is genomics. And that's the first thing. And the second key now in COVID care is if there are vulnerable groups, immunocompromised groups, to save lives. So I think that's where the whole pandemic has evolved now. And we have to live with COVID. So we know that COVID is going to be endemic like dengue, malaria. And we have to learn to live with COVID and identify and triage the people at risk and give them appropriate care and behave responsibly. So that's really the overarching theme today. And I'm grateful that Cipla continues endeavor for educating physicians at large. So with us, we have one of the foremost genomic experts, microbiologists and molecular biologists, not only in India, but worldwide. She's a world authority for the last 4 decades. I've personally known her for almost 3 decades, Professor Jayanti Shastri. She's head of molecular diagnostics. She had original experience in retroviral diseases, then Hep and Hep B, Hep C. She has seen the variants, then the recombinants of HIV-1 and 2 strains. And then in the last couple of years, she's, apart from being the head of department at Nair Hospital, has also been heading the molecular diagnostics at Kasturba, infectious disease dedicated hospital, which was bearing the brunt of the COVID. So she's going to tell us cutting edge on genomics on the COVID variants in circulation from an Indian perspective, predominantly Mumbai and Maharashtra, but overall from an Indian perspective. So Professor Shastri will first give us a glimpse and how it is important, because right now the threat of first wave was ancestral strain. The threat of the second wave was probably the Delta strain, and the Delta was wiped off by Omicron in the third wave. And now the so-called, there's not really a fourth wave, but whatever is the silent cluster outbreaks we are seeing is all linked to Omicron. So she's going to give us insights and she has all the facilities with her. So whatever the facilities they may be there in the US or Europe, we have it in Mumbai. and she's been at the forefront of this cutting edge research on GSAD, on INSACOG. She has been expert everywhere. So Jayanti madam will give us an insight on the COVID variants in India today, Mumbai specifically, her own experience, and then what's her thoughts worldwide. Being a microbiologist par excellence, an excellent teacher at heart, and a good friend and colleague of ours, she will give us the insights on the genomic standpoint. And then we'll move to treatment options with Subro and Prashant giving us some glimpses on what's novel and new in therapeutic world. So over to you, ma'am. You're muted, madam.
Thank you very much, Dr. Vaishali, Dr. Shashank, for your very, very kind introduction. And I will be just giving you a glimpse about the current COVID-19 variants in India. So the question which all of us ask are we out of the woods? What is this new variant which is, showing up and again wreaking havoc? Are we going back to 2020? I just would like to share with you that what are variants and why do they occur? The variants of the viruses occur when there is a change or mutation in its genome, which is actually expected. It is a very, very natural phenomenon, especially with RNA viruses, which are error prone. And around 2 mutations per month is natural and normal. But there is a constant change. There are lots of permutations and combinations occurring, and that is called as recombination. And that is very important for the virus for adaptation to new hosts and also to the environment. We go back to the Darwin's theory of survival of the fittest. Now, the viruses, they evade immune systems. They, in fact, select themselves as a natural phenomenon due to mutation. And that is why we see the variants. Now, every variant is not associated with severity, increased transmissibility. What is its efficacy with reference to the vaccine, with therapeutic medicines? Can diagnostic tools diagnose them? Can they detect them? And of course, all other public health or social measures. And we have also seen that some variants, they just disappear, while others, they persist. So this is a normal phenomenon of natural selection. So we are bound to have variants. Now, in 2020, we had the Wuhan strain. The Wuhan strain was the novel virus, and we had unexposed individuals, and that is why we saw the first wave. Then what happened was vaccination was introduced as early as January 2021, and the healthcare workers and frontline workers were vaccinated, and there was a majority of population which was not vaccinated. And that is why there was mutation, and we saw the Delta variant causing the second wave. So why is there a need to know the circulating variants? I'm just setting the stage for you to understand why is variant identification important. In my earlier lectures, I have told you that PCR is a diagnostic molecular test which only tells you the presence or absence of the virus. Whereas it is also important for us to know what kind of the virus it is. Because evasion by diagnostic kits, because we see S gene target failure in some viruses. The alpha strain, the Omicron, they did show S gene target failure. So the kits which are directed towards the S gene, you will not be able to detect the presence of the viruses. So you should use diagnostic kits which detect either the N gene or the ORF gene in order to have a foolproof of diagnosis. Do these variants cause increased transmissibility? What is the impact on the clinical disease? Now, today we have reached a stage in the pandemic where impact on clinical disease is extremely important. Vaccine efficacy is extremely important as an endpoint of the disease and not the numbers. That is something I think all of us have been talking about, that numbers may increase, but this is what we need to monitor. Whether these variants, monoclonal antibodies, the therapeutics which are available are efficacious. And of course, variant identification is extremely important for epidemiological surveillance. So there are a couple of things about the variants which we need to understand. The SARS-CoV-2 variants could be variants of concern. These are all labeled as by the WHO. The variant of concern will have higher transmissibility or detrimental change in the COVID-19 epidemiology. It will have increased virulence or change in the clinical disease presentation, decrease in effectiveness of public health and social measures or available diagnostics, vaccines, and therapeutics. When a variant satisfies any of these criteria, it is labeled as a variant of concern by the WHO. So in UK, in May 2020, we saw the Alpha variant. And we also know that the RNA viruses are continuously evolving in the genetic code due to the error prone in the replication. So why was it a variant of concern, the Alpha strain? Because it was spreading very easily. And we could see by December 2020, Alpha strain, the Alpha variant was very common in the UK because of its increased transmissibility and virulence. In South Africa, in August 2020, we had the B1.351, that was the beta variant. Then in Brazil, we had P1, the gamma variant. It spreads easily and some vaccines may be less effective. October 2020, actually as early as October 2020, we did have certain strains, but we reported a lot of Delta cases late March 2021 and early April 2021. But it spreads easily, symptoms were present differently, reduces vaccine efficacy, but still protects against severe disease. Now, this was the time around April 2021 where we experienced the Delta wave in India, and I will show you some glimpse of that also. Then B1.529, that is the Omicron. The 1.529 in multiple countries, early studies show that it spreads more easily. Well, around December 2021, we could see a number of cases of Omicron. The variant of interest and variant of monitoring, there are other variants. The earliest we reported highest transmissibility in the Wuhan strain was when we demonstrated the D614G mutation as early as May 2020, even causing a lot of cases of reinfection. Now, the reinfection manuscript, which we wrote up at that time, we saw that the reinfections were caused by this variant, which causes D614G mutation. Variant of interest contains mutation which is predicted or known to affect transmissibility, evasion of immunity, and diagnostic testing, and identified to cause significant community transmission. Of course, there are epsilon, kappa. Kappa is a variant of interest, and we saw a lot of cases of kappa early in the pandemic. Iota, lambda, mu. We were, in fact, wondering how come we did not see the mu strains, which was very prevalent in certain parts of the world. Then, of course, November 2021, Omicron. The other variant is variant under monitoring in case of any specific mutation which we see commonly in the samples which we sequence. Now, the methods of variant identification. So whole genome sequencing is, of course, a foolproof method. It is a gold standard. And since our lab is doing the variant identification by whole genome sequencing for the private as well as the public health sector in Mumbai, the labs as well as the hospitals, we have this facility. We have a high throughput facility, but it is a bit expensive and expertise is required. We have a very higher, and it takes time. It is a bit time consuming. However, it is a gold standard method. And if available, it should be brought into good use. But I would say that it should be, the use should be in reference labs. What do we have in the labs? What you can do is a variant specific PCR. The turnaround time is less. It is less expensive. The only disadvantage is it cannot identify new variants, need to be assessed for a number of sublineages, cannot differentiate between sublineages. I'll give you an example. So we are using Tata MD Check RT-PCR Omissure, which can detect Omicron. And fortunately, all the sublineages of Omicron, which are prevalent as of today, it is able to diagnose and test. When we test, it is able to detect. So the Candida novus is supposed to detect BA1 and BA2 separately, whereas the Omissure only tells you whether it is Omicron or not. It does not differentiate BA1 and BA2. So we just come to know that it is a Omicron or a Omicron sublineage. Now, what are the various variants which have been circulating in India? So the Indian SARS-CoV-2 Genomics Consortium is INSACOG, is the agency which monitors the variants in India. It is jointly established by the Ministry of Health and Family Welfare, the DBT, CSIR, and the ICMR. So what did we observe? We observed earliest, we actually did see this was the Wuhan strain, and then we had a fair amount of alpha. Then you can see delta. Now, when the delta blue is so big, it does not mean only delta. We also saw a lot of delta sublineages, which was, we called it the AY lineages, sublineages. So you can see that the delta almost started as early as 2021 and it remained almost till November 2021. But I would like to share with you that by September, October, we saw a lot of AYs. AYs were the delta lineages. And this was completely wiped off by the Omicron. Now, Omicron did have a survival advantage. It had high transmissibility, and therefore it wiped off the delta. And from November 2021 to almost the last sequencing which we have done, we have been seeing a lot of Omicron and Omicron sublineages. You can see the top variants over selected weeks. We are seeing a lot of 2.12.1, then 2.38, 2.10, BA.2, Omicron. Now, why is it important? Because as I told you, the therapeutics. Now, the clinicians will tell you about the role of therapeutics in the Omicron variant. But it is again very important for us to know whether it is a BA.1 or BA.2, because for therapeutics, it is again very important to understand which of the sublineages they are. So this is what we have done in Mumbai. This is the data which has been generated in our lab at the Center for Genomic Epidemiology and Surveillance for Pandemic Preparedness. We have been doing whole genome sequencing from August 2021, and to date, we have sequenced 4,000 SARS-CoV-2 positive samples. So you can see that early on, we did have some alpha, then the delta and sublineages. We had a fair amount of kappa also in August 2021. So right from August to December in Mumbai, we saw the delta and sublineages. And later on, we saw there was a whole lot of Omicron. So currently the circulating variants include BA.2, that is Omicron, and its sublineages BA.2.38 and BA.2.12.1. Now, I would like to share here that this kappa, though it is known as an immune escape variant, we did see that most of the patients, they did not have severe disease. The hospitalized patients had very good outcomes. We had only one death due to the kappa variant, though it was an immune escape variant. Omicron also, what we are seeing currently in vaccinated individuals, the outcomes are very good. Every variant in unvaccinated individuals, individuals with comorbidity, individuals who are immunocompromised, as well as those on immunosuppressive therapy. These are the individuals who have to be extremely cautious. So again, I would end by saying, yeah, though we are not out of the woods, however, I would say, like Dr. Shashank Joshi said, we have to learn to live with the virus. The virus is going to be in and around. We have to protect ourselves by getting ourselves the boosters, the precautionary dose, and ensuring that our immunity is strong enough to prevent any severe disease. With this, thank you very much for a patient hearing, and thank you, Cipla, for this opportunity. I would be very happy to take questions in the panel discussion.
Thank you so much, Professor Jayanti, for this very insightful overview, including some original work. You have always been at the forefront in India on this, and we will have a panel discussion at the end of the three speakers. We now move to our next speaker, Professor Subramaniam. Vaishali has already introduced him. He is one of the foremost infectious disease and critical care experts in India. He has been at the cutting edge in critical care and infections in India. And he's going to give us a case story on the monoclonal antibodies and their role, and some insights in the current therapeutics in the COVID world. He has been at the COVID, he has been a COVID warrior right from the inception of the pandemic. And beyond that has done work, some seminal work in infectious disease and tropical disease in India. Over to you, Dr. Subramaniam.
Thank you. Very generous introduction. Thank you for that. So I'm going to talk about where we stand with regards to the monoclonal antibody. Beginning of the year, we were wondering if it's time for us to kind of say bye-bye to the monoclonal antibody. And this is obviously a case which we are writing up for our national conference. And it's in no way unique because we are seeing this to be a recurrent theme. So this was a 61-year-old gentleman who was actually in pretty decent shape. Although he's diabetic, hypertensive, and hypothyroid, he was actually in good shape, well nourished and not with major issues. Last year, during the major COVID wave, he actually was diagnosed to have a low-grade B-cell lymphoma because he presented with fever and underwent treatment with rituximab and bendamustine. And his last cycle was in August. And he had both of his doses of COVID vaccine in May and June of last year. And obviously, he's been very diligent in taking care of himself. He did have history of COVID-19 infection in December 2021. We don't know what the strain is, meaning obviously it was not sequenced, but we do know that he did require oxygen support. Therefore, it was severe COVID, but he was treated with pulse of steroids. I'm not sure why it was pulse steroids, but that's what he got. And with that, he apparently improved very, very slowly. Apparently, he was on oxygen for more than 2 to 3 weeks, even at home. And then slowly he started regaining his strength. And about a month later, he started having some fever. And actually, when he came to us, the history was that he had prolonged fever for nearly a month and a half. And this has been continuous for the last couple of days. This fever was, which he was initially describing, was intermittent. And because he was going round and round, he decided he had been referred to our team to try and do a deep dive to find out what was happening. And when the family came to us, he said he's been febrile for the last 5 days continuously. And now he also had some exertional dyspnea, dry cough, loss of appetite, and fatigue. And he had already had extensive workup outside. And on the advice of his primary physician, he has been on a slowly tapering dose of steroid for quite some time now. In fact, when he came to us, he was on prednisone, which was about 8 milligrams of dexa equivalent. I think he was on 40 milligrams of prednisone by mouth at the time when he came to us in the OP actually. When we saw him, he was conscious. He looked quite sick and he looked very tachypneic. His blood pressure was fine. He was desaturating on room air, and on 4 liters of oxygen, his saturation picked up to about 98%. Obviously, you can see that he was tachycardic and tachypneic. There were basal creps, and so to sum up, this is a 61-year-old diabetic hypertensive hypothyroid. He is immunocompromised in that he has had 6 cycles of rituximab and bendamustine for lymphoma last year. He had recent severe COVID 4 months ago, and he was on oxygen support continuously for 2 days, but intermittently for 2-3 weeks. Was treated with pulse steroid. Now he's on has a PO with increasing oxygen requirement, and he's currently on steroids, about 40 milligrams of prednisone. So we evaluated him, and we did a HRCT and a respiratory biofire, because we were not just looking for COVID, we were looking for all kinds of pathogens. None of the other pathogens were identified, but they clearly found the SARS-CoV-2 again. So this cannot be SARS-CoV-2 from the previous infection that was more than 4 months ago. So this is a new COVID infection, and again, a new severe COVID infection. And we did a detailed workup to see if there was any additional opportunistic infections which was causing the severe illness, and there was nothing. And we suspected that all of this was probably related to the rituximab. Now the question is, what is to be done with him? This is a gentleman who is worsening in spite of prednisone, 40 milligrams or 8 milligrams dexa equivalent. Therefore, we just converted the prednisone to dexa, and that's all we did. We were uncomfortable about giving him TOSI simply because he's already extremely immunosuppressed with a lot of steroids and with the bendamustine rituximab last year. And therefore, we had a long discussion, and we only gave him the monoclonal antibody in addition to continuing the steroids. Other supportive measures like oxygen, nebulization, and all that stuff was given. And a repeat CT scan actually showed that there was clear worsening of the lung function, of the lung parenchyma, as compared to a previous CT scan outside. So obviously, he had both a clinical worsening and a radiological worsening along with the positive PCR, which established that this was a recurrence of severe COVID. And he was already on steroids, so it was not that we could introduce steroids again. But with the monoclonal antibody, he started improving, so much so that we decided to finish off the full dose of monoclonal antibody. We first gave him 1,200 milligrams. And once we saw that he started improving, we actually gave him the other 1,200 milligrams to give him a total of 2,400 milligrams. And he actually improved pretty fast. The improvement was actually dramatic. And this was a gentleman who was very rapidly becoming hypoxic to the point that his oxygen requirement now started stabilizing, and his hypoxia started resolving. And the CRP also started showing a decreasing trend, mirroring the fact that his inflammation was coming down. His fever came down, his general sense of well-being started improving, and repeat X-ray showed some amount of resolution. And he was improving, and then he actually went home on 1 liter oxygen support. And on follow-up now, we can confirm that he no longer requires any oxygen support. So this was a situation where, actually speaking, this was a recurrence of severe COVID. And it's interesting because certain groups of people are not covered in the conventional sense. So cancer chemotherapy, while they're on chemotherapy, we think of them as high risk. But some of the newer drugs that we have, like rituximab, have very, very long-lasting effects, especially if multiple doses are given. And studies have shown that they deplete your B cells so powerfully that your B cell mediated immunity is practically wiped out, which probably is what happened to him. And that would be the only explanation why he had 2 episodes of severe COVID back to back. And he did note that the first time he had severe COVID, the response to therapy was slow and it was labored. But with the monoclonal antibody, he started improving much faster. So it is important to note that there is now more and more data coming out about COVID infection lasting longer and more severe in patients who undergo powerful B cell depletion, like with rituximab, and they're also probably liable to get recurrent episodes of COVID. And this is one place where we've decided that in patients where their immune system is really weak like this, the monoclonal antibody seems to suggest make sense. I wish I could say this was the only case where we did give monoclonal antibody. We've had other cases of rituximab use, especially where they've ended up with severe to even critical COVID, and they have responded to the monoclonal antibody. But then again, we've been using a higher dose, 2400 to sometimes even 4800 milligrams, and with that, we are seeing a response to it. And with that, I will stop. I think I can take questions during the discussion.
Thank you so much, Subramaniam. This is so insightful. I mean, you gave us such a wonderful story of the B cell depletion, which did not allow this individual to mount any antibody response, and then elucidated the role of monoclonal antibodies. So there is a clear role in those most severe cases. Now we switch gears to a colleague of mine, a good friend of mine, Professor Prashant Sajed. He's trained fully in India. He's also trained in Switzerland. He used to publish a lot then, and he continues publications. He's going to give us some insights on the Omicron therapeutics, the role of molnupiravir, the role of remdesivir, which came back in office practice again with a very elegant publication in New England Journal of Medicine. So Prashant is a interventional pulmonologist, but beyond that, doing his critical care pulmonary medicine, does critical care and pulmonary medicine. He also does a lot of office practice, very good in his bronchoscopic work, very well known in therapeutic bronchoscopy. So Prashant is going to give us some insights, just like Dr. Subramaniam, on the role of molnupiravir and remdesivir in the current Omicron scenario of the COVID pandemic. Over to you, Prashant.
So thanks a lot, Shashank, for this very generous introduction. And what I plan to do in the next few minutes is just give an overview of some of the recent trials where we have seen the role of molnupiravir and remdesivir, and then I'll move to the case scenarios, and probably we can take the case scenarios also as a part of the panel discussion. So when we look at we've seen the data on remdesivir, the pendulum going in, initial data, initial excitement, then there was the pessimism about remdesivir, and then again, some of us continue to believe in remdesivir because a lot of the data of remdesivir initially, which led to the pessimism, was from the data because the trials used remdesivir, after 1 week or 8 days of the onset of symptoms. And at our institutions, we continue to use remdesivir earlier on. And then we had this data which came up and said, if you use early remdesivir, then that helps to prevent progression to severe COVID-19 in outpatients. So this is the pendulum shift that we have seen with the remdesivir. There was one more paper which came earlier, even before this current paper I'm showing you, is remdesivir plus baricitinib versus remdesivir alone. So it was interesting to see that remdesivir in that trial, where they wanted to look at the efficacy of baricitinib, was compared with remdesivir in both the arms, and it looked at the so the remdesivir became the standard therapy in these patients where baricitinib was used. So to come to this was a randomized, double-blind, placebo-controlled trial, non-hospitalized patients with COVID-19 who had symptom onset within 7 previous days and who had at least One risk factor for disease progression. Those were the patients would include the age was more than 60 years, there was obesity, and there were certain coexisting medical conditions. Now, in this group of patients randomly assigned to receiving remdesivir intravenously for 3 days only, that is 200 milligrams day 1 and 100 milligrams on day 2 and day 3, and placebo. So the primary efficacy endpoint in this case was related to hospitalization or death from any cause by day 28. And the primary safety endpoint was any adverse event. And the secondary endpoints were, a composite of a COVID-19 related medically attended visit or death from any cause by day 28. So if you see here in this particular graph, it's very clear that here you can see the days since randomization, and then here you can see COVID-19 related hospitalizations or death from any cause. Now these were the patients. You can clearly see the marked difference between the placebo and remdesivir. So clearly showing the benefit of remdesivir in this particular case. So the conclusion from this paper was, among non-hospitalized patients who were at high risk for COVID-19 progression, a 3-day course of remdesivir had an acceptable safety profile and resulted in an 87% lower risk of hospitalization or death than placebo. Now, the point here to be taken is that here it was early use of remdesivir compared to the earlier studies where often the remdesivir was used after day 5 or day 7. Now, quickly shifting gears to this molecule called molnupiravir for oral treatment of COVID-19 in non-hospitalized patients. So when we look at remdesivir, we say, okay, remdesivir, we are using it for our IPD patients. And then that came the concept where you could give only 3 days of remdesivir that has been shown to be effective and only on an OPD basis in the high-risk individuals to reduce the risk of hospitalization and death. And what we saw in the US is a lot of these booths being set up in the COVID centers where individuals would come in, take the remdesivir and go back. But what would be really desirable is an oral therapy which would help to treat the individual at home. So this was also called as a move out trial. This was a randomized, double-blind, multi-site study. It was a phase 3 study. We had more than 1,400 patients who were randomly assigned to molnupiravir treatment or placebo. And this was conducted at more than 170 sites globally. The inclusion criteria important were non-hospitalized patients, confirmed COVID-19, and the onset of symptoms had to be within 5 days of starting the medication, and at least one risk factor associated with the poor disease outcome. And I think the risk factors we are all aware of. The important point here is again onset of symptoms within 5 days, because we have whatever experience we have with antiviral therapy. We have seen that antiviral therapy, the earlier you give, the better it is. The exclusion criteria in this case was the need for hospitalization, any dialysis, pregnancy, unwillingness to use contraception, etc., and of course, COVID-19 vaccination, SARS-CoV-2 vaccination. If you look at the primary outcome here, it was to evaluate the percentage of patients that are hospitalized or die within 29 days of randomization. The most common risk factors, again, for poor disease outcome, which were included were obesity, age more than 60 years, diabetes, heart disease. And what you clearly can see here is that there's a 30% reduction in the rate of hospitalization or death in the molnupiravir group. And therefore, this became a very interesting study. The interim data, however, had shown that there was a 50% benefit, but the final data showed that there is a 30% reduction in the rate of hospitalization or death in the molnupiravir group. So to conclude, the move out trial showed that molnupiravir effectively reduced the hospitalization or mortality risk in patients with mild to moderate COVID-19 infection. And of course, mainly we looked at individuals who had some high risk factors. Now, what I'm going to do is I'll just take you through clinical scenarios, what we come across in day-to-day basis, and that's where we need to do some decision making. So this is a scenario where you have an individual who's 65-year-old, diabetes, hypertension, and has been diagnosed with COVID-19 infection. So this is something which we need to tackle, and we have to see how we use our current armamentarium daily in the management of COVID. We'll discuss this as we go. So this was also discussed in the earlier lecture by Madam, where she said that although we've seen decreased virulence and all, we have to be very alert in the patients who are high risk, such as elderly, diabetes, hypertension. Another scenario, you have an individual who's operated for breast cancer. She's on chemotherapy and she gets COVID-19. How do you tackle these individuals who are on chemotherapies and immunosuppressive agents? Now, the third scenario, we've had a patient who's got scleroderma, who's got an interstitial lung disease along with that, and she's on immunosuppressive therapy. And I'm sorry, there's a typo here. This individual is on mycophenolate mofetil and on nintedanib, and now this individual develops COVID-19 infection. And the last and another scenario I want to discuss is a 30-year-old male who's got borderline diabetes, oxygen saturation is normal, and now has turned out to be COVID-19 positive. And now another 45-year-old female patient, fever is persisting for 3 days, is diagnosed with COVID-19 patient. How do we tackle these patients? Now, from an approach point of view, how would I treat these patients? If you look at this 45-year-old female, fever is persisting for 3 days, diagnosed with COVID-19, my approach for this individual would typically be symptomatic treatment and budesonide. I'm a big fan of budesonide because we've seen that budesonide we've used for decades, and we've had fantastic data which came from the various trials which were conducted in the UK and showed that this inhaled budesonide remarkably helps in the reduction of severity of symptoms, early recovery, and also reduction and reducing the chance of hospitalization. And therefore, budesonide is something that I would use for this individual. Would I use molnupiravir for this individual? Because molnupiravir has been shown to reduce the days of symptoms and help with early recovery, along with the reduced risk of progression. But for this individual, initially I would have a high threshold to give an antiviral therapy. Budesonide would be first. But now, if the fever is persisting, fever is not breaking down, and the individual is really broken down with the fever, we have to discuss. And in the panel discussion, we'll take it up whether we would give molnupiravir to this patient. Another individual, 30-year-old patient, borderline diabetes, saturation normal, RT-PCR positive. What would I do for this individual? Again, if you ask me, I would give this patient budesonide. It's really safe, and we've hardly seen any complications. And I think in clinical practice, anecdotally, brilliant results with budesonide in this group of patients. Moving down now, third case scenario, you've got a patient who is now this patient immunosuppressed. Now this patient is immunosuppressed with mycophenolate mofetil. She's on nintedanib, also for the interstitial lung disease. Now this is something that we need to discuss. Should this patient get molnupiravir at home? Should this patient get a 3-day course of remdesivir, either on OPD basis if the facility exists rather, or do you hospitalize these patients for remdesivir? And I think this is something where these are the group of patients which we have discussed need more attention. So what we've seen in the current outbreak is it's a mild infection. Most of the individuals will do fine with symptomatic therapy or budesonide, but it is these group of patients who are immunosuppressed. You've got underlying malignancy, as you see in this particular case, who need more attention. And I would have a low threshold for this case number 2 and case number 3 to give intravenous remdesivir just because of the clinical circumstances. And now we come to this first scenario, which I explained to you, discussed with you. 65-year-old male patient, diabetes, hypertension, diagnosed with COVID-19, is saturating well at home, has got no breathlessness. Of course, I would give this patient budesonide, but I think this is an individual where I would consider to give oral molnupiravir at home. Again, we've looked at it reduces the risk of progression and helps to get early symptomatic relief. And because of these comorbidities and age as well, I would consider molnupiravir for this group of patients. And with this, I hand over back to you, Shashank. And we can also, I'll be very open to have views and discussions on these case scenarios, because these are the clinical scenarios that we are facing on a day-to-day basis. Now we see that most of the patients who are, who don't have comorbidities, who are getting a flu-like illness, most of these patients don't reach to a specialist. But I think these are the group of patients who need more attention and we trust. Over to you, Shashank. Thank you.
Thank you so much, Prashant. This was very insightful. And you and Subro virtually mix and matched very nice cases and scenarios which we see in clinical practice. So my initial questions are to both of you. with the current scenario of Omicron variants, which Jayanti madam described, what are the clinical presentations? We saw the Wuhan strain clinical presentation. We saw the Delta strain clinical presentation. So I want from you, Prashant, and from Dr. Subramaniam, what is the clinical presentation of COVID cases which you are coming across currently?
So,
is there a difference?
Currently, what we
and
are
I'm also
now,
going to have an additional question, Prashant, that what is the percentage of patients, this is particularly to you, who are needing hospitalization and needing oxygenation? And then I'll come back and probably Subra will give his own experience, because there has also been a little geographic change. So you are from Mumbai, Subran is from Chennai. We are seeing some differential geography, and then from that question I'm going to come back to Madam Shastri again. So Prashant, sorry, go ahead.
Yeah, so Shashank, I think that is very important. I think what you brought up, the symptoms that we see in current patients are fever lasting maximum for 2 days. A lot of the patients have upper respiratory symptoms. They've got a cold, they've got a sore throat, throat irritation, myalgia. Some of them have headache. And also what we're seeing are abdominal symptoms. Many patients are also coming with just abdominal symptoms and loose motion. So these are the common symptoms that we are seeing in majority of the patients, I would say. I would say most of these patients, if they are not having any comorbidities, are young, are being treated symptomatic therapy. Other group of patients, like you, I said, you asked me what percentage of patients are getting hypoxemia. I would say very few. Just last week, I had a patient who had, who had a saturation of 84. We did a scan for 25 to 30% lung involvement. But I must tell you that is very, very unusual in this scenario. So this patient, after a long time, we actually saw a significant lung involvement in this patient. This patient was obese, had post-CABG, hypertension, diabetes, hypothyroid. So these were the comorbidities, and underlying obstructive disease. These were the comorbidities that individual had. This patient has now recovered well. So clearly, this was the patient who got IV remdesivir. We gave him steroids also, and he's recovered well. So this is, I must say, very small number of patients who are getting hypoxic. Who are the patients who are getting hospitalized? Again, I would say a very small number of patients. Particularly, we've had, I think we've struggled, I think at least I've struggled to administer just remdesivir on an outpatient basis. Patient comes and goes. That's not been possible. But in these selected high-risk individuals, particularly, I would say those who are having an underlying maybe immunosuppressive status or having an underlying malignancy, recent or ongoing therapy, these are the group of patients I would get them into the hospital, and depending on the severity, give them 3 to 5 days of remdesivir. I've started to, for the most stable patients, just give 3 days of remdesivir and send them home. And of course, the other group I said were those patients, majority of them, if I wanted to give antiviral therapy in these high-risk individuals, I would say, I would give them molnupiravir.
Dr. Subramaniam?
Yeah. So I think he has summarized it very beautifully. A couple of things I'd add. The majority of patients are going through COVID without symptoms, number one. Number two, we are seeing a significant minority of patients who have no respiratory symptoms but have COVID. I've had patients who present with symptoms which looks like, say, dengue, a lot of back pain and body pain without headache, without respiratory symptoms, and it turns out to be COVID. The dengue tests are all coming back negative, but COVID has come back strongly positive. So right now, the rule of thumb is very simple. Anybody with a short duration fever, the first diagnosis is COVID, the second diagnosis is COVID, the third diagnosis is also COVID. Don't go for other diagnoses till you've ruled out the first three. So that's the easy rule of thumb. What's happening is that, unfortunately, people have forgotten to screen for COVID. So a lot of hospitals are having oops admissions, where patients are coming with short duration fever. They get admitted for evaluation, and people forget to do the COVID testing. And 48 hours later, somebody comes along and says, don't we need to do a COVID test maybe? And then, oops, there is a COVID test in this. That kind of stuff is happening. Fortunately, severe disease is not so bad. But I will say that I am seeing a few more cases of severe disease now than in the last couple of months. The numbers are slowly starting to rise. But I definitely agree, it's primarily in those people who are either unvaccinated, but that's becoming a very, very small minority. It's primarily in those with a very weird immune system. I mean, I'm not talking about diabetes or heart disease and things like that. I'm talking about people with significant problems. I'm still curious to see what kind of effects it's going to have in terms of precipitation of heart attacks and strokes and things like that. I think that's what we need to look at. Those signals would also be interesting. Now, of course, I think there is more long COVID now with Omicron than we have ever seen before. My own personal feel that what I'm seeing right now, a significant minority of patients are presenting with longer symptoms and weird stuff, including fogginess and dementia-like symptoms and things like that, going on for months on end. So I think those are all going to be major problems as well going forward.
Yeah, go ahead, Prashant.
Yeah. So, I think, Sudra, what you mentioned is very important. We're seeing many patients with long drawn symptoms. The common symptoms of long COVID, I think we're seeing more long COVID symptoms now than what I saw, I'm not sure, until what I saw last year. The symptoms being, these patients are just not able to feel, fatigue during the day, not wanting to do anything. And we've seen several patients with myalgia and headache. We've also seen several patients in the last few months who claim that, since the onset, since they had the COVID in the Jan-Feb time, they've had an increased bronchial hyperreactivity. So, we've also seen patients with a new onset bronchial hyperreactivity in the current in the current wave. Also, to say that we've also seen mixed infections. You mentioned about dengue and malaria. So we've started to see more and more, because what happens is that this individual comes with fever, you check for COVID, but whether the COVID actually accounts for all those symptoms, so it's really becoming very important to get into the depths of it. And we have diagnosed patients with malaria in the last few weeks, who also had concomitant, COVID.
Yeah, thanks, Prashant. So, Madam Shastri, I have two questions for you. You can take both of them together. One is that diagnostic microbiology in COVID space, I think, has been the most rapid evolution on planet Earth. We never saw such a fast evolution from a properly detailed RT-PCR, which is to take a couple of days, to a rapid test at home. So, everybody has asked the question. A lot of people, even on the group, have asked the question: how reliable is this rapid test? And one of the reasons that the actual numbers are not visible is most people do a rapid test. If they test positive, do we really need to do an RT-PCR? Is there a role for RT-PCR today? And if the RT-PCR rapid test both are negative, but if the suspicion is strong, do we still need to repeat it? So that's the first group of questions. And second is related to the strains which you are looking at. In addition to BA2, are you still picking up BA4, BA5? And even today, is there anywhere in the INSACOG analysis a delta still seen? You did make a passing mention of Kappa, but is that still being seen? Because a lot of the BA2 variants may have a behavior like a delta. We don't have that strong clinico-microbiological correlation, because by the time our yield on molecular variant analysis crept up, the cases suddenly shrunk. So therefore, it was not easy to handle. And we are grateful to you that you are continuing not only in public health space, but even in the private sector space, aiding all our hospitals to give their clinicians answers in these areas. So, ma'am, your first insights in the diagnostics, and the second insights on the circulating variants currently.
Yeah. So to answer these two questions, see, number one, the home tests which are being used, they are known to have compromised sensitivity. Having said that, I wouldn't say that all of them are bad. But if you do not have access to RT-PCR and you want immediate test results, of course you should do the home tests. But if it is negative and you have, say, any of the symptoms which our clinicians have just mentioned, I think it warrants an RT-PCR. But strangely, I'll tell you what happened in the Omicron scene. I wouldn't say now, it was few months back. We saw a number of antigen tests coming positive, which were RT-PCR negative. So we started sequencing So I hope the clinicians know that the antigen test is collected in a lysis buffer because it is done in outpatient services, whereas an RT-PCR is in a proper VTM. So we did try, sequencing some of the samples which were collected in the lysis buffer. But fortunately, it turned out to be a false positive. So this is also a scenario which we have been seeing. And so we told the CDSCO to send us, kits for batch validation. So what has actually happened in diagnostics? Somewhere, the quality checks on the batches have also gone down. So it is important for the clinicians to know that please go by your gut feeling of the symptoms and your clinical diagnosis. Of course, a diagnostic test will support it, but these are certain nuances of the diagnostics which we have observed. I think I have learned all the lessons in diagnostics in the last 2 years, which in my 38 years of service, I did not learn. So we did so many PCRs from 2007, but this is like a googly, I tell you. And coming to the strains, in fact, I really have this question with the clinicians. Does it matter to you whether it is BA1 or BA2? Of course, it matters to you whether the individual is immunocompromised, has comorbidities, on immunosuppressive therapy. But do you want to know exactly whether it is BA1 or BA2? Because the literature suggests that, monoclonal antibodies are efficacious in BA2 rather than BA1. So if that is the case, we need to increase the numbers of variant PCRs we are doing in the lab, because only few labs are doing variant PCR for reasons I don't understand. If it supports the clinician, I think we should all do it. So, Shashank, answering your classification, we have seen confusion in the pangolin when it comes to classification. And you would be surprised that to date, we have a number of strains which are unassigned, even by Nextclade and pangolin. Reasons, I don't know. There are a number of reports also coming that BA4 and BA5 are actually wrongly reported as BA.2 because of the errors in classification in the software itself. I think the pace at which the virus is mutating, the softwares are not getting validated, or I'm so confused many a times. One day it is XE, one day it becomes XJ, and I don't know where they have gone out of the window, all the XEs and XJs, and now it is all about the BA.2. Now, again, I would request the clinicians to closely watch this BA2.38, which is in large numbers in our population. We have just finished the 13th round of sequencing yesterday. In the hospital samples of Mumbai, both private as well as public hospitals, we are doing sequencing for entire Mumbai. And we have a large number of BA2.38. Now, what is important is you have to clinically correlate it and see in a vaccinated individual how the clinical disease pans out. Answering your question on BA.4 and BA.5, it is still there, but it is not in as large numbers as BA2.38.
Thank you so much, ma'am. I think two important take-home messages. That a rapid test could be false positive. I think that's a big underlining message. Second is the quality control of rapid checks and batch-to-batch validation is a need of the hour. And the third is RT-PCR still holds true and is good. And fourth is the true value of genomic sequencing. I think from a clinical standpoint, I'll take a little bit of that. But it's very crucial for us to understand because therapeutic responses definitely have a challenge. And the major point which you're saying is the current prevailing Omicron within at least the Mumbai or around Maharashtra population, and Mumbai is again a conglomerate from all over India, is BA2.38. That's the strain to watch. 4 and 5 are there. And taxonomically, as they say, by the time we understand something on the COVID virus, either in diagnostics or treatment, COVID virus has moved to the next station and the next destination. So we are always sort of, one station behind them, or one destination behind them. That's really been the story of COVID across for the last 2.5 years. So we are trying to catch up fast. I think the virus and the evolution has caught us faster. Fortunately, the displacement of Delta, ma'am, is probably complete. Would you agree with that? I don't know, but I think probably Delta more or less has got extinct. And I think I can say that with confidence, ma'am.
We had only one Delta out of 279 in the last batch. And in the current batch, which was sequenced yesterday, we didn't have a single Delta.
So more or less, that's very, very minuscule or absent. Yeah, Prashant.
So my question is, madam, last week this individual whom we had was, with a 25 to 50% lung involvement. The thought that came to our mind is whether this is Delta. So the question is, Subra mentioned that in the last couple of weeks, he starts to see more and more of low respiratory involvement, some hypoxemia. So, are we, what variant would this be, madam, then?
See, if clinicians are interested, please send us the samples of your atypical cases, and we will support you with the genome sequencing data. Here, we have to work this way because, see, you have questions and we can support you with the data. But if you have atypical cases, please send us the samples.
Yeah, because I think we sent this, we'll follow this up. I think I had asked our microbiologist to send it to you.
Yeah, great. So I think this is very interesting.
Just from a clinical perspective, madam. So, if we are seeing my questions, maybe I've missed some parts of the understanding. But if we see hypoxemia, I want to know from all of you also is, is it a variant of, I know Omicron can get severe, we know that, but it's been really unusual for us to see a 30% lung involvement in the last few months. So would this be, can Omicron do this, or do we start suspecting Delta? That's my question. I know we will send it to you, but from a clinical perspective,
what about the host? What about the host? Host immunity is again something, and especially the cellular immunity of the host, which we need to study when you have an atypical case, and we can support you in that also.
Sure, thank you.
Ma'am is not only now doing viral diagnostics, but she's also running in collaboration with IIH and many other centers across Center of Excellence in Immunology. So she will also be able to give you some immune signatures, because the immune signature which Dr. Subramaniam presented, the rituximab completely depleted the whole B cell lineage, and therefore there was inability to mount the antibody response. So I come back to both Prashant and Dr. Subramaniam probably can take this. The role of monoclonal antibody in the BA1 variant was not there, and probably we all dismissed it off. But with the advent of BA2 and BA2.38, there is a likelihood in an underlying situation where the immunity may be compromised, or there may be severe comorbidities. I'm not talking of general hypertension, diabetes, which Prashant was alluding to. Those office practice patients where probably a molnupiravir and a symptomatic treatment with maybe paracetamol round the clock will do. Probably the severe cases, they do get lower airway involvement. And there may be a role, if not a regular dose, a double dose of casevimab or indivimab, and that's the case Subramaniam highlighted. So I still feel that there could be, and as Prashant is saying, we are seeing a little more hospitalizations now. We are seeing some lower airway diseases, and it's also possible that this is a filter, because these are the individuals who probably were holed in for a very long time. And we also saw people who never got COVID for 2 years. They are getting COVID now. So that's the other question I'm asking to the both clinicians. That we are seeing breakthroughs, whether it was Bill Gates, whether it is Tony Fauci, whether it is our current couple of people, they never got COVID in the whole 2.5 years. But now they are picking up the virus. So I remember my good friend Vasant saying that COVID will enter every household, and eventually will have a breakthrough or an infection to everyone. So, what are your thoughts on that? This is but my primary question is around the monoclonal, because, if you go to say a place like Dubai, they have the GSK antibody or the Astra antibody or the UK or US, and then they have their triages. But in India, we have only one. Double dose of that, probably in a BA2 scenario, in situations which you all see, particularly Dr. Subramaniam and Dr. Chajet, probably there may be a role coming back again beyond just remdesivir. So what are your thoughts on the antibody? And as I talk about the antibody, are you still seeing cytokine storms? Are you still using an agent like tocilizumab or a baricitinib? Because WHO only a month back put it back on the protocol. So, you know, the protocols are still evolving. So what are your thoughts on the antibody, the baricitinib, the tocilizumab? Do you still feel there's a role for this?
One thing I can say is that WHO has more often got it wrong than right in the last 2 years. So let's just leave it at that. But having said that, I'm just going to comment on the other issue that you talked about. There's a very beautiful saying in English: time wounds, all heals. And looking at the epi curves in China, where there was very strict lockdown, it made no difference. The R naught is so high that even a blunt instrument, a powerful instrument like a lockdown, made no difference to the epi curve, which basically means the R naught is insanely high and there's nothing you can do about it. So the most important thing is you just accept it that it's going to happen. And you're right, we are seeing a lot of repeat infections in our patients. And I'm just wondering if the patient that I just presented, whether he had Omicron BA1 and then BA2 now. I can't prove it. You know, it sucks that I can't prove it. It would have been lovely. And actually, there is some data that's come out from the West where they've shown that infection with the Omicron, at least the BA1 variant, tends to downregulate your immune system a little bit, and therefore makes you more vulnerable to repeat infection and things like that. Very early data, but obviously very, very creepy data. Now, coming to the more important point that you said. So the problem is that we are now cherry picking the most vulnerable of the patients for severe disease. And in those patients, it's really petrifying to be using a blunt instrument like tocilizumab. Tocilizumab was great. So I'll put it like this. Last year, when we had Delta, when we had younger patients with very severe disease, the risk-benefit ratio was clearly towards using toci. But now, in this patient, let's say, I have got a guy who is I've already wiped out, well, the oncologist has wiped out all the B cells and literally wiped the floor with it. And I go and wipe out what is left with toci. You know, I might as well strangle the guy. So while I love toci and I think it really had a place, today I would rather be cautious in using toci, and I'd use toci as my backup and knight in shining armor when everything fails, rather than use it a little upfront. So what I've realized is, at least my team has also seen this, and actually my team was the one who noticed this, and they called my attention to it. I can't take credit. That with the monoclonal antibody with a higher dose, even in patients where steroids are ineffective for various reasons, we are seeing a good benefit. And obviously, it's reserved for those who are high risk, or especially when the oxygenation is just starting to become a problem. They are starting to develop more lower respiratory symptoms, or their oxygenation is starting to take over, and we are able to pull them back with this. Even those who came into critical COVID, we've been able to pull them back. Yeah, it's a little tricky, but I think it should be reserved for the critically ill, those who have had significant immune depletion due to these new designer drug, recent cancer chemotherapy, which has been fairly aggressive, like in hematology, oncology, and possibly organ transplant, which is recent and things like that. Outside of that, I'm not sure if it's going to make a big difference, but I would definitely use it in those circumstances.
Yeah. So if I can just add here, Sujal, I think I think Subal made very important points. I think the point we said, there are some patients who are just on the brink, and you think, yes, we need to intervene. I think that is one of the indications where we have been using the monoclonal antibody. One more area where I would say I've got a low threshold to use the monoclonal antibodies. Again, these very very high risk individuals, were very elderly, octogenarians, or comorbidities, etc. I think again in these patients, I've got a low threshold to use the monoclonal antibody.
I think Prashant, I think we all agree that the severe immunocompromised host, as Jayanti Madam was saying, the host will decide the nature of it. And I think the double dose of antibody definitely has some data now to suggest, particularly from the recovery data also. Using it late also, because initially the thoughts were use them in the first 3 days or 7 days, but they have used them in the recovery also, and they have got mortality data. So it's still stood the line. It's armamentarium, like what Dr. Subramaniam showed us, that wonderful case. I think in absence of the antibody, probably would have lost the patient. So I think I'm very certain of that. I mean, so these are life-saving molecules. They are still with us very much, and we need to use them judiciously, appropriately, and correctly. And we also have armamentarium molecules like tocilizumab and baricitinib and etc. But we have in the oral space molnupiravir. It went through a lot of churn, and Prashant rightfully said that it still has a role. Somebody has persistent fever above 50 with a lot of comorbidities. It may not be a bad agent to use at all. And it has hardly any drug interactions. Are there, both Dr. Subramaniam and Prashant, are there any new molecules? Do we really need the Pfizer compound in India? I'm told DCG has already approved it. It's just a lot of manufacturers are very reluctant to launch it because of two reasons. One is that they didn't see the takeoff of molnupiravir. The amount of favipiravir we used or remdesivir we used, which went virtually out of stock, we didn't see that type of a takeoff. And in a patient comes in the hospital, the remdesivir new data, which Prashant so nicely presented, has been pretty compelling. So obviously, it's a no-brainer to use remdesivir for 3 to 5 days. So what are your thoughts on the ritonavir boosted, nirmalatavir options which are available? And there is some rebound concern which surrounds that. So what are your thoughts on it? And do you think there are some more new drugs in the pipeline? Because COVID is going to be around. It's not going to be over for sure. So because then I'm going to move on the questions of boosters. But before I move to boosters, I'm going to go back to Dr. Shastri on what's new in diagnostics like saliva, etc. So both Dr. Subramaniam and Prashant, what are your insights on this? The new drugs in pipeline, the Pfizer drug, do you really need it for your patients in India today? What's this controversy about rebound?
So I think, Dr. Prashant, please go ahead.
So I think as much as we want new medications in our practice, I think if we look at the current scenario, I think in the current scenario, I think we seem to be doing reasonably well with our one of my favorites, which is budesonide, and using the antibody cocktail as required, and the molnupiravir, and the remdesivir. So I think at the moment, and of course you mentioned about the baricitinib process in selected patients. I mean, I must admit that having used baricitinib and tocilizumab for a while at the moment. So again, that's looking at the current scenario, the current virulence, and the current morbidity caused by the current variants that we have. So I think maybe that is one of the reasons why I think the other molecules might find it difficult, to get their presence here in India, because like you rightly say, they thought molnupiravir would work like the favipiravir work. But clearly, I think what has happened over the period of time is, I think we've started to group our patients, segregate our patients much more better clinically. And I think today, a large number of patients, I think we are not administering anything more. They're just so symptomatic, and a selected patients on the current therapies available. So I think Subra, I'll be interested to know in which scenarios you think these other additional drugs would be helpful, and in where we would place them in our practice.
So the point is that I think this is a multifold problem. Number one, people have stopped testing for COVID. When you don't test for COVID, you're not going to find COVID, and you don't find COVID, you're not going to treat for COVID. So that is problem number one. Number two, people have now convinced themselves, not just physicians, in the community, and the government has also gone into overdrive saying COVID is no longer a problem, which to some extent is a good thing. But that also means that you're now going to have people who are denying COVID and saying, no, I don't have COVID. Or if they get severe COVID, they'd rather have other things being tested for and things like that. So for a lot of reasons, COVID treatment is now going to suffer because of resetting the clock back to 2020, where we were in denial. As far as boosted PIs are concerned, boosted by ritonavir, boosted PIs are always a great option. We know what they did for HIV. And protease, the gene, is usually the most preserved gene amongst all the genes that the virus expresses. And therefore, the chance of resistance breakthrough is very low. And when you have a high threshold drug like a boosted PI, you're not going to get viral resistance very, very quickly. It's pretty difficult to do that. And unless a person is a complete back job, you use it with rifampicin or something like that, you really are not going to do that happen. So I think it's a lovely drug. It has value. Problem is the market is going to shrink because people don't think there's value in treating COVID. Finally, the breakthrough issue is an issue because remember that the viral loads in Omicron are insanely high. You can't compare Omicron viral loads with Alpha, Delta, or Wuhan variant because they are exponentially much higher in magnitude. So the duration of therapy is probably wholly inadequate. And when you're especially talking about people whose immune system is really bad, we know that they are higher viral load and prolonged shedders as compared to people with very good immune system. So, when we start reserving the drug for our most delicate and most vulnerable patients, it also means that we are opening ourselves to the possibility that they could bounce back again. So again, should we retreat them? What should we give them a longer duration of therapy? All these are unclear. And I don't blame the pharma industry because with the focus being away from COVID and people being told that COVID is no longer a problem, I think the market for it is going to shrink, and the interest in investing in a molecule like that is going to go lower. Although it's unfortunate because I believe it's a very, very good drug and definitely much superior to the drugs we've used so far, oral drugs at least.
Thank you so much. I'll go back to Madam Shastri. Madam Shastri, 2-3 things. One is, and then I'm going to come back again to our clinical colleagues. One is in the diagnostic space, salivary space has come up in a big way. Secretion space and diagnostics have come up in a big way. So that's one area which I want to answer. Second, you made a passing reference that the vaccinated versus unvaccinated, though we see a small percentage of unvaccinated population, mortality still is very high in the unvaccinated group. In fact, I think across India, and you need to publish this data, ma'am. It is very important to recognize that the most deaths which are occurring today, we need to do an audit and you need to publish it in public domain, are occurring in the unvaccinated population because there has been some degree of vaccine hesitancy. So what is your thoughts on the vaccination? See, we know for sure vaccination doesn't prevent disease, but definitely is an immune booster. But vaccinations clearly have a role in death and severity. That's for sure. But that's the second part of my question, because you have seen it directly, because you are looking at the variant, you're looking at the mortality, and you're looking at it, and you have direct access to all that data or insight to all that data. But my first question is in the diagnostic space. From the day one only, we were listening to there'll be a salivary tool, there will be a nasal secretion tool, and more or less, I think the rapid test more or less replaced it. But you said the quality control of rapid tests is not sacrosanct. The sensitivity is quite low. So do you really feel also inhaled therapeutics? Do you feel in these areas of diagnostics, so there will be some insights, some advances, or this space is also getting saturated like the therapeutic space?
See, way back in 2020, we were eagerly awaiting a saliva test because it was actually there was enough evidence from Hong Kong and Singapore and all these places that they are using a very good saliva-based test. But we got about 2 kits from ICMR for validation, because ours is a validation center for antigen testing kits and RT-PCR kits. But however, their performance was abysmal. So we had to, we could not include it. But recently we do have certain studies from NIRI Nagpur talking about saline gargles and doing RT-PCR, and the turnaround time of the test results is very less. However, we have a pan-eating population, and I don't know how well it will be, sensitive and specific in this population, and what kind of oral hygiene which is required. With all these things, as of today, we do not have any ICMR approved saliva-based test. However, NIRI is doing the saline gargles and RT-PCR. Now, actually, if you remember, we did present in the state task force that most of our patients who died, had mortality, were all unvaccinated, even in Omicron. So was the case in Delta. So yes, we are in the, we do have access to all kinds of data. We should definitely not sit on the data, and we are publishing at least the various variant specific immunological data. So my actually question to the clinicians is, we have a good study which we are writing up, the immune signatures, both cellular and humoral in the Delta variant. However, with a 90-day follow-up of these patients, do you think it is important for us, or if it is possible, should we do a follow-up of these Omicron positives, especially BA1, BA2, and look at their immunology?
So absolutely, ma'am. I think I will ask, of course, Prashant and Subramaniam. But madam, one thing Dr. Subramaniam mentioned, I am telling you very frankly, if somebody gets a BA1 compared to a BA2, the immunological paralysis or immune suppression is much more sustained compared to a BA2. And worldwide, this has been observed, particularly in North America and Europe, that if somebody got a BA1 maybe 4-5 months back, they get very vulnerable to get other infections as well as a BA2 within 6 weeks to 6 months. So this is a very well standardized observation. Probably as Subramaniam said, that this is a very high viral load, but also probably it is depleting our immune system in a much more differential way compared to the regular ones. And currently we don't have any new variant of concern or variant of interest in the horizon. And because it has beautifully wiped off Delta, the hospitalizations and severity has substantially come down, except a severely immunocompromised host. But God forbid a breakthrough into a VOC or a VOI occur. And it can occur anytime. That's the fear, which is why WHO is still very, very skeptical. And I agree with Dr. Subramaniam, the amount of faltering they did in the beginning, they are now so much on the tenterhooks that they don't know. But I think, ma'am, it will be very valuable to look at the immune signatures, both in B and T cell lineage in these variants. And it will also be insightful to know, because we also need to know that we are now looking at a hybrid population. We are looking at a population which is vaccinated with 2 doses and or a booster. And we are also looking at a population which is had 1 infection or 2 infections with different strains. So knowing their immunology will be very crucial in this space, because most of the Omicrons have been breakthroughs, either through a vaccine, full or partial, and or to an old infection in the past. So clearly we have that coming up. So my question to Dr. Subramaniam and Prashant is, vaccination has come down. There is a booster hesitancy. There is a lot of confusion whether it should be a homologous booster or a heterologous booster. So what are your initial thoughts on it? And do you strongly believe that the dent in the hospitalizations which we see today, and the severe disease and the mortality which we see today, do you corroborate the evidence generation which Dr. Jayanti said, that currently we are seeing a lower proportion vaccines have had an impact overall on public health? Do you feel so? They may not have made a dent on the population of the numbers of virus, but they clearly have made a dent on the disease profile in terms of severity and mortality. Do you feel that that observation is a valid observation? Dr. Subramaniam first and Dr. Prashant later.
Yeah, that's an interesting question. I think it's even more interesting to see the difference between what's happening in India as compared to Western Europe and North America. I think that difference is even more sinister. They are moving forward with the 3rd and the 4th dose, but their attributable morbidity or hospitalization rates seems to be far in excess of what ours is. And, makes me wonder if maybe we hit the jackpot with regards to the vaccine. Right, so maybe we got the vaccine right and maybe they didn't, is what my gut instinct is. And I wouldn't be in a hurry to pass the judgment that things are better, because I don't know if you've seen this new tweet which has come out from one of the groups about this new variant which somebody has coined Balrog. It has all the escape mutants of Omicron, but it does not have any of the severity attenuating mutations. It's a cute name, Balrog. But anyway, point is that I think we may be having a bit of a honeymoon phase as compared to the Western world, but that does not necessarily mean that it's going to last. We are hoping, we are optimistic that we are doing well and we continue to do well. But again, see, weird things like this immunity hyper attenuation and things like that. We don't know where all this is going. I think it pays to be on our toes and continue the work that people like Dr. Jayanti Shastri are doing, because that is absolutely critical. We need to know what the hell we are handling. And we've been bitten by this before, and I'm hoping we have learned our lessons from that. But I think it's going to still take some time for us to figure out where we are heading, because it's still a very mixed picture. Each part of the world is heading in a different direction, and it's only getting worse. It seems to be pulling apart in so many different directions, and I don't know which is going to come out trumps, whether it's BA212, BA4, BA5, or a new one which is going to come out. I think only time will tell us. But I do believe, honestly, if I had a personal choice, I would go for heterologous vaccination. In fact, I haven't taken my precautionary dose. I'm still waiting for the conjugate vaccine.
You opened a hornet's nest. Prashant, any thoughts?
Yeah, no. So I think very, very, very interesting, very interesting, Subra, your perspectives. And I think all of us are curious also on several of the points that you mentioned. My gut feeling is, I always felt that the vaccination is the thing that has helped us to reduce the severity of the disease. To the extent I thought that we have so many asymptomatic or really very very mild symptomatic infections, and somehow I attributed that to the vaccine. So I think whatever is feasible right now, whatever is permissible right now, I think I would still encourage that even the precautionary doses be taken, because one of the observations that has been that the many people who have not taken the precautionary dose are the ones who are probably getting more longer duration of the symptoms, and therefore seeking more more specialist healthcare. Just an observation, just anecdotal, but I think that may be the case that if you miss the precautionary dose, it's been more than almost 9 months to a year since your second dose, it's possible that the symptoms may be longer. So again, my faith towards the vaccination combination, whatever is available. Second, one point I wanted to highlight is that although we've seen a reduced, I mentioned this earlier also, although we've seen a very reduced risk of hospitalization, severe disease, etc., but we still continue to see several patients who have these respiratory tract symptoms. They have symptoms of bronchitis. Some patients are even after we discussed recently, you guys discussed about the reduction in immunity, what it might be doing to immunity. We've seen several patients getting repeated respiratory tract infections. We've seen several of our COPD patients who got infections, who got the COVID in Japan, continue to get more and more frequent exacerbations and linked to infective exacerbations. So I think again, it's very interesting. I think again, and therefore the immunological signature, madam, as you asked, would be very important to understand the immunology. What is the current variant doing to the immunity? And it would just allow us to be more vigilant on more specific aspects in the high-risk individuals.
Shashank, with your kind permission, I just wanted to share, there was a publication from Kalyani, the institute in Kalyani, who had, I am so sorry, I can't remember the particular enzyme studies in the human gene. They had very clearly mentioned that the European population is deficient in that enzyme producing gene, and that is the reason they are, they were associating the genetic predisposition, linking it. Of course, the study sample was very less, but I think we should, direct and focus some studies on this racial variation and the role of certain genes in predisposition. I think it's high time we do not blame the virus completely and focus our attention. These are expensive studies, but I think somewhere we are lacking in our knowledge in understanding the human genetics.
Ma'am, you're very right. In fact, the Rockefeller group was the first group to show that there was a HLA genomic signature which actually identified a susceptible patient versus non-susceptible patient. I have to thank Prashant. He's really got a lot of patients waiting. So please, we will excuse you. Thank you for all your contributions and keep doing all the excellent work you're doing. But I'm going to continue the conversation with Dr. Subramaniam and Jayanti for just a minute or more.
Thank you very much.
Yeah, I think we'll just go ahead with what Jayanti said. I think we need to continue doing the research. And as I echo what Dr. Subramaniam is saying, it's people like you who will give us insights on ground zero, because otherwise we are at loss. And as we are, closing this whole wonderful session, we have therapeutic tools, we have diagnostic tools, but genomic surveillance has to remain. Immune surveillance and identifying immune stroke genomic markers is a need of the hour going in the future. COVID is definitely becoming a seasonal disease, like a flu, but much more than a flu, because it has some sinister implications even today, particularly in a compromised host or a severe host with lot of comorbidities. So clearly that is there, which is there. I think that's something which I think we all recognize. I think it was very insightful to have a couple of our top clinicians, our top microbiologists, and we need to do more of these meetings. So I really thank Vaishali and the entire CIPLA team for continuing science. This is a scientific endeavor. You have been in the forefront of the COVID pandemic in terms of therapeutics, whether you have molnupiravir, which is oral, whether you have remdesivir, which is injectable, whether you have a monoclonal antibody, which still has a role. If you see Dr. Subra's case, and it has a life-saving role. And the molecules still have a role, life-saving role. Though the treatment of the current COVID appears to be predominantly a symptom-related disease, in absence of in an immunocompetent state. Vaccines have some role. They definitely have made a difference in the overall biology of the disease. They have been immune booster or immune adjuvants, to say the least. They may not have been the true vaccines where you prevent disease, but they definitely have made some dent on mortality, some dent on severe disease. That's for sure. Which vaccine, how to use it, which platform, these are all work in evolution. Do they have adverse events? Probably yes. So I think it's very important. Jayanti Madam's coordinates are with our team from CIPLA. We'll be more than happy. She's a very good collaborator with clinicians across the country. So including Subra, I'll be more than happy to receive some interesting atypical cases, because ultimately the support we get from people, Madam Shastri, is very unique today, because we are able to find and get some directionality and answers, because we have one common goal worldwide, is to save lives, number one. And number two, try to mitigate severe disease, whether it's treatment tools or diagnostic insights. That's really our overarching goal. So I'm really thankful that CIPLA continues doing this exercise. Dr. Rajadhar, I'm told, due to some current engagement, couldn't join us, so I had to fill in last minute, though I am recovering from my Omicron now, and I had a little extra time. So I agreed with Vaishali to chip in last minute as a moderator. But thank you so much, Vaishali. Thank you so much, Madam Jayanti. It's wonderful to see you again. I will send you what Subra was saying. I tweeted in the morning on that little variant which has come out in public domain, single case, unlikely to be replicated, just like those old recombinants we saw in HIV, probably. And Subramaniam, thank you. It was wonderful to see your case and wonderful to talk to you again on these virtual forums. I still feel there are some physical meetings happening, but I think virtual learning is the need of the hour. It's inexpensive. You can do it across board. And I think, as I said, we are all committed for patient care and for good science. And it's an evolving science. We are learning. All of us are students at the end of the day. So thank you so much, Vaishali, and your entire team for putting this up together. Thank you.
Thank you so much, sir. So thank you so much,
Vaishali. I personally would like to thank you. It's been really wonderful. And Shashank, please add it saves travel in Mumbai.
So thank you so much, sir, for accommodating our last minute request. So I really thank Dr. Shashank Joshi, sir, for moderating the session so well, for putting forward all important clinical situations, important clinically relevant questions, and having such a wonderful panel discussion, for setting the context and summarizing it so well at the end. Thank you so much, sir. I thank Dr. Jayanti Shastri ma'am for giving us the overview of variant of concern and mutant variant of concern and mutant variant of interest right from the inception. What is the current scenario in India, and for presenting her very interesting data on genomic sequencing, and also for showing the readiness for having more genomic sequencing for across India, and also sharing her current research on immune signatures, which is really interesting. Thank you so much, ma'am, for that. I thank Dr. Subramaniam Swaminathan, sir, for presenting such an interesting case on immunosuppressed individual, and also sharing his views on positioning of various COVID-19 drugs in current scenario. I thank Dr. Prashant Chhajar, sir, for presenting on the latest data on efficacy and safety of newer drugs like molnupiravir and 3-day remdesivir therapy, and sharing such common scenarios, and what should be the appropriate treatment options in those scenarios. I thank all the panel members for sharing their clinical experiences, sharing their expert views, and it was a wonderful discussion. I'm sure our audience has benefited from that. I thank our audience for spending their valuable time with us. Thank you so much to all of you. Thank you. Signing off now. Thank you so much, sir. It was a wonderful discussion.